Hello, everyone. You are on This Is My Offer, and I'm your host, Dr. Abdul Shaikh, and I'm the global leader for population health at Amazon Web Services. Today, we're going to be exploring how innovative technology is reshaping healthcare delivery with Innovaccer, a valued AWS partner. As we know, providers and payers are facing significant challenges with rapid changes in technology and the policy environment that's resulting in immense cost pressures, labor challenges, variance in care delivery, you name it. And so we're going to speak with two leaders from Innovaccer today to learn how they're helping healthcare organizations overcome data fragmentation, data interoperability, while improving the provider experience and driving patient-centered outcomes. Let's welcome our guest today. Anil?
Well, thank you, Abdul. I'm Anil Jain. I'm the Chief Innovation Officer at Innovaccer, and I've had a very long career in health IT. As an internal medicine doc and as a clinical informaticist focused on our migrations from electronic health records to really solving some of the thorniest issues that are confronting healthcare providers and their administrative staffs today, I'm really excited to be having a chat with you today.
Wonderful and welcome. Amy?
Hi, it's nice to be here with you and your viewers. My name is Amy Stevens, and I'm our General Manager over our providers and payviders that are using our platform. My background is 20 years running hospitals and health systems, as well as clinical integration networks. And from there, went into building a technology company that assisted buyers in picking what type of technology will best solve their problems and get them the performance they need. And that ultimately brought me to Innovaccer because I believe many of the problems we're solving are fundamentally solved well here.
Well said. Well, let's dive in. I want to start by having us think through the healthcare data challenge. We know that costs are going crazy, right, in healthcare. I think the latest estimate was in 2024, we spent almost $5 trillion in annual spend on healthcare. And so, Anil, what do you think are the biggest gaps in healthcare today, and how does Innovaccer help customers address them?
Yeah, well, let's go back to when we were trying to basically promote the use of electronic health records among providers and hospitals. You talked about the money that we're spending on healthcare, but think about the amount of money the federal government has spent on bringing EHRs to doctors and hospitals, $36 billion. And the whole point of the electronic health record was to help clinicians do a better job in managing care. But in the early days, they were nothing more than glorified electronic versions of what we used to do on paper, documentation, and perhaps some level of billing. But they really weren't the kind of tools that clinicians needed to properly manage their population of patients, even the panel of patients that they might have had to manage as primary care physicians or as specialists, the patients that were coming in for referrals. So one of the biggest gaps that we have seen, and one of the areas that in my career I've been focused on, and especially here at Innovaccer, is how do we bring all this data that's required to understand what's happening with the patient? How do we bring it together? So when you think about the way Innovaccer is approaching this problem, think of it as a layered cake. On the very bottom layer, the foundational layer, if you will, we think about all the variety of different data that needs to come together. And in the early days, most of us clinicians and the folks that would work with us would be screaming about, well, we are rich in data, but very poor in information. Then we got to a point where we started using this data to create insights and information that helped clinicians. But then we started screaming about how it's information overload. There's just too much information, not at the right time, not at the right place. So the next layer from the data and then the analytics is really understanding how do we inject the insights into the appropriate places in the workflow. And we'll get into a little bit more of this in a little bit. But that is a critical piece, because if you present the wrong information at the wrong time, or even the right information at the wrong time, that's not very beneficial. And now what's happening, and I think with our data activation platform, how to make that data as meaningful as possible as we go from data to analytics to insights to workflow, is how do you now take advantage of the advances that are happening around AI and generative AI, conversational AI. So really thinking about our maturity from thinking about data activation to a health intelligence platform, where the ability for us to sort of predict what a clinician might need to see or their care team might need to see, helping engage care team members with patients through advanced technologies. And again, we'll spend a little bit more time on this a little bit later, but through the co-pilot mechanisms where I might have an AI assistant looking over my shoulder, helping me manage my patients, or care team members manage their panel of patients, or thinking through what the latest and greatest is. And if you're making a hotel reservation somewhere in Vegas, you're using an agent that you're basically telling it how many people and roughly what time, what kind of food, and it's doing almost everything for you. That's semi-autonomous agents. We call that our agents of care, and that's at the very top of our layered cake. Really going from data to analytics, analytics to insights, insights to workflow, workflow from automation, and again, what we are calling our sort of health intelligence platform helps accelerate this vision from a data activation all the way through health intelligence. Having said that, this is the biggest gap in healthcare for providers today, which is we have spent a lot of money bringing advanced technologies, but can we now start to make those advanced technologies work for us instead of working against us?
Mm-hmm. Mm-hmm. Great
Makes sense.
points. Just the reference to how we are rich in data and poor in insight, and we've been struggling with this idea of interoperability to actually drive our use of that data. And so your reference to both the data activation platform, but also on top of that, it's this maturity of really looking at health intelligence, right? And you have your health intelligence platform to do that. Amy, can you give us an example of this, and how Innovaccer is working with providers to be able to help them harness that data?
Yeah, we're excited about the type of insights that are now going directly into workflows. And even more than that, a nurse, a care agent is not waiting for them, that they can be prompted unaided. Like, here's information you need and you didn't even know. And in many cases now, there are pieces of that work that can be automatically done by an agent. So you're really accelerating what those insights look at the point of care, the point of engagement. A great example is such a common occurrence within healthcare, and that is when somebody has been discharged, whether that's from inpatient or they've been discharged from an ED, for instance. We know that it's good care, and in many cases also contractually obligated, that that patient be followed up on in a timely manner for their own sake, also for the contract's sake, but then also in order to avoid something like a readmission or a decline in their health. Right now, on average, when a care manager gets that new file, they have an alert that we have a patient who's had some type of an interaction and a discharge. That when they get that alert, it takes them about 10 minutes to go through a patient's record. In our case, we have that sitting in what's called Patient 360, a product that allows you to use our health intelligence platform to see a longitudinal record of that patient, well beyond what you might see just in your own EMR or just from claims data. It can even bring data from competitors in, from retail pharmacies, imaging centers, to be able to look at that patient. But that person, that care manager, has to quickly spend some time just to understand why is this person in my queue and what do I need to do? And we give them some prompts to do that. They're going to spend on average 3 times reaching out to that patient. They spend about 10 minutes looking through the background to figure out what am I going to do. Then they're going to spend about 3 times reaching out. And about 30% of the time, if they're lucky, that person will answer after 3 tries. That means that 10 minutes of learning and those attempts were for naught, right? Now they're going to go on to the next patient. And you can see this repeated over and over through the day, weeks, months, how that adds up. It also just wears on your team who were there to do good things. And now they're just stuck in this administrative morass, right? So what happens now is an agent can go in. It can perform that scan, that 10-minute scan, if you will, but in a matter of computer time, not human time. From that, it can glean, why should this person get an outreach? It can initiate the outreach, this automated agent, and say, I'm an agent calling you on behalf of Dr. Jain. Can you answer a few quick questions? And we want to schedule a time for a human to call you back that's really convenient for you. In doing that, they are gathering some additional information, and that patient feels a sense of being seen. You're calling me when I want to be called. That means our success rate of that person answering the call is about 60% higher. So you can see throughout this whole interaction, we've reduced the amount of time that's being spent on people who never respond. When they do respond, we're getting additional information. And then when the call does go from the human, they are significantly more likely to answer it, and they're in the frame of mind ready for the call. That's an example of how you're fundamentally changing workflows.
That is so important, right? Because if you think about it, you want to lower the burden on providers. You want to really help decrease, the time they spend on tasks that are not really providing value. But you're also thinking about the patient, right? And their
Absolutely.
ability to also benefit from that exchange.
We're starting to see that AI is actually considered more empathetic than humans in some ways. It's giving us the chance to provide highly personalized care, highly personalized engagement, and they have unlimited patience. They aren't tired and hungry. They have the ability to just have a fresh start every time, and it's tailored to what that engagement needs to be.
I love that. Do either of you have any examples of a customer? Because both our organizations are very customer focused, where you found that they're getting value from this.
I think if you extend what Amy just shared with us, and you think about the provider, you mentioned the provider burden. Well, you think about a typical primary care physician, and we have all heard of the concept of pajama time. These are docs who work from morning till evening, go home, perhaps have dinner with their family, and then boot up their computer and finish documenting what needs to be done. And you combine that with the relationships that providers are struggling to really manage around all the data that needs to be collected and so on. So an example of a workflow tool, an application that we have built, something called InNote, and soon that is going to sort of mature into something we're calling a provider co-pilot. Going back to the examples I was giving earlier about using AI to help support the individual physicians as they practice, the ability to start having the physicians be aware of what the most salient care gaps might be, or the most important opportunities to help accurately code the medical record so that there is an optimal care being given for the patient, but then there's also optimal reimbursement happening for the health system. Those are all very, very important things through our InNote application, and again, through our provider co-pilot. One of our customers, what we're hearing from them is that some of their doctors are saving an average of 30 minutes on patient encounters, and that could add up to quite a bit. And now they can choose what to do with that time. Do they want to see more patients, squeeze a few more patients in that might be on a waiting list, or do they actually want to spend a little bit more face time with each of the patients as they go through? Our goal is to reduce both the administrative and cognitive burden through these tools. It's both. Clinicians are seeing increasingly more complex patients. We are also asking physician extenders to start seeing patients that typically have been reserved for medical MDs or other professionals. So there's an efficiency gained if we can serve up the right information at the right time for the right providers, make it actionable, make it integrated into the workflow of their electronic health record, and allow them to continue to focus on what's most important. And I think Amy said something really, really important. The empathy that we can achieve if we do the AI right is incredibly important to us. There is a shortage happening among primary care physicians and nursing professionals. And I think we can complement the experience that patients have by using technology in the appropriate ways.
That's pretty incredible. 30 minutes daily saved. Calculate that to weekly or monthly totals. That is significant, and it goes back into then allowing providers more time with patients, right? More time to really drive that connection and trust building that's necessary.
Yeah, and Abdul, that's just simply from taking what's in the medical record and surfacing it up at the right place at the right time. There are things that Innovaccer is working with our customers around the ability to support ambient documentation, having us be able to sort of create those transcriptions and eventually write notes that can help support the care process as opposed to just supporting the billing process.
Right. I love that. And then maybe avoid some of that pajama time, right? That
Absolutely.
really
That's
is
what
not.
we're seeing right now.
Yeah. So we've talked about at a broad level the challenges around data and interoperability and bringing it together to make it actionable. And then both of you have provided some really compelling points around improving the provider experience and how to integrate that into workflows and provide better care and lower the provider burden. It makes me think about what we talk about as a modern data strategy, right? What is the data strategy for your customers? And so the question for you, for both of you, either of you can take this, is knowing that a strong data foundation is essential. How do you help healthcare organizations drive and develop that cohesive data strategy to take advantage of all these advances?
Well, I'll give it a start, and then Amy can add on. I think one of the things that we have to recognize, there is no AI strategy without a data strategy. AI requires robust organization of data. And so one thing we help our customers understand is that you need a robust data strategy if you're going to do any of the wonderful things that we just spoke about. So what does that mean? It means knowing where the information is coming from across the organization, understanding the regulatory side of data sharing and what it means, and you kind of alluded to this earlier, Abdul, but what it means to be interoperable, not just at the noun level, but at the verb level.
Mhm.
Understanding the context of the data that's being brought in, how was the data generated, what are some of the issues that the data might flow along with it. For example, the metadata that says, hey, this blood
Mhm.
pressure my patient was actually taken while they were sitting, not while they were lying down. And the ability to interpret that downstream is going to be critically important.
Mhm.
One of the nice things about Innovaccer is that we bring a data model to our customers so that we can help organize some of that data into the most useful use cases. And we know this. It's not easy having a data model and then just saying, here you go. So it's really the extracting from the source systems, transforming the data in a way that makes sense, and loading it into the appropriate places in the data model. We
Mhm.
support our customers in doing that. Having the business rules that says when Dr. Jain on a Friday evening, really tired when he was documenting the medical record, and accidentally put that the patient was 6 inches tall instead of 6 foot tall, what is that gonna how is that gonna be reflected in the data? So the cleanup of the data. We know that if you have, garbage in, garbage out. So everything from the data provenance, the lineage, to making sure that we're redacting nonsensical data, and all the way to taking the data model and then saying, what are the verbs that you want to do with it? Are you doing
Mhm.
quality reporting? Are you doing quality submission? Are you going to drive AI models? And making sure we can support some of those different actions with this data. We'd
Mhm.
like to think that Innovaccer helps organizations collect the data once, organize it once, and then reuse it multiple times for different use cases, whether it's dashboards, whether it's the kind of workflows that Amy was speaking about, or some of the physician tooling that I mentioned earlier. But that is a critical piece. When we do our checkups with organizations, and I'm sure you're discovering something similar, is that
Mhm.
oftentimes they might have 8, 9 different copies of the data scattered throughout the enterprise.
Mhm.
And our goal,
Missing data,
missing,
you
yeah,
name it.
absolutely, absolutely. And everyone has got a bit of a different fiefdom when it comes to data. So data governance and understanding who's who in the zoo that's managing this data so that we lower the risk and liability that an organization has having all this HIPAA, what I call HIPAA radioactive data, is another important thing that we do as part of our initial implementation process. I don't know, Amy, if you want to add a few comments to that as well in terms of what you're hearing from leaders in health systems.
Yeah, maybe it actually leads right into our next topic, which is about outcomes and ROI. What you just described, Anil, never happens in the outcomes and the ROI unless we have a good data strategy and a good data platform. So many times, as a leader myself, I sit in operational meetings and I'd say, but are we doing better? Have we improved care? Are we seeing more patients? Are we using empty time slots in specialist offices that are going unused and yet people are waiting 6 months for a dermatologist, right? Are we bending the cost curve? And so frequently the answer was, well, we don't have the data to really pull that together to see it. Or it's going to take an army of 12 people in 3 months, in order to get to it by then the data, the outcome that you're trying to manage a business off of is just dated. So when we think about that ROI and outcome, we're looking at what problems are you trying to solve, and then can those data strategies support it? And by feeding the right applications, so for instance, agents of care that we've talked about, in care for us is a care management tool. The tool that Anil talked about that is at the point of care for all kinds of providers, physicians, therapists, pharmacists. InNote is that sort of platform within a platform that we use. All of these different applications are ultimately tied together in a unified data strategy that gives you that patient 360, that a far more enhanced view of the patient at any given time. And what's really critical is the pharmacist that's looking at the patient and the doctor that just pulled up their report to see if they're meeting the measures for the payer. They're looking at the same data in the same moment of time. It's not, well, my report was dropped off a month ago by somebody from the clinical integration network, and I already closed those care gaps. Why are you here yelling at me about that? Versus somebody said, no, this is what I'm seeing our ED utilization looks like. So that the only way that you can manage a business in a modern way is, in fact, to fix that underlying data strategy and the integration and the alignment of your various products and applications sitting on top. And when you start to do that, you start to see radically different ROI. So for instance, by being able to hook different applications together, like a care management tool with a point of care tool. For us, that's InCare plus InNote. We see a 30% improvement in communication between care managers and physicians. A physician says, I noted that this patient needs a referral for some type of total wellness. Think of housing, food, etc. That care manager gets that alert immediately into her work queue, which can trigger an automated feed to, for instance, a community organization to be able to manage for those other types of impacts that impact our health. So the ROIs that we are seeing range from revenue improvement, for instance, more slots filled, in-network retention, being able to, we have a referral tool, a referral management tool. How do you do referrals better? Being able to design your contracts with payers and see how a network would actually perform. We have a network optimization product. We have a contract design product, and one that also looks at revenue reconciliation on the end. Did I get paid what I expected to be paid? And if not, how I could change that. We have provider scorecards as part of our product suite so that that network, that set of physicians you're engaged with the whole time can be looking at their performance. All of those things change the ROI from finance, quality, engagement, experience. And of course, that clinical outcomes reigns number one.
That is so important. And I really appreciate, at Amazon, we talk about working backwards from our customer needs, their pain points, and that's exactly what you're describing, right? And you want to help them think through how to make that data usable, put it to work, right? Because you're thinking about the data, you're thinking about the governance, the analytics that goes on top of that, and the specific types of end users, be they on the administrative or the care side. And I love that. These measurable outcomes and ROI are important. Well, let's talk about AI, right? I know that we talk about AI in every meeting we go to, and AWS is very committed to enabling AI-powered transformation. You've talked about agentic AI, using other types of machine learning, for example, to predict care gaps. Can you tell me a little bit more? And Anil, this question's for you. How is Innovaccer integrating AI to drive efficiencies in care and in decision making?
Yeah, so I think the broadest statement would be that we're trying to bring AI to almost everything we do. Everything we do to develop our software and solutions, to how our users will be leveraging that with a bit less of a cognitive load and administrative load. So in some ways, we're taking many of the applications that we spoke about, which may have had traditional machine learning risk models, for example, or traditional AI models to predict, for example, readmissions to the hospital, and asking ourselves, can we start to chip away at using agentic AI or using large language models, using any form of some of the advances to start to take away some of the low hanging fruit, low level activities that are high effort, but really can be done by machine, if you will, and start to expose that to our users and say, we listen to the conversation between a doctor and a patient, and we think here's what the summary of that visit looks like. And in fact, we believe that here are some diagnoses that we ought to be considering as part of that dialogue. And in fact, if you believe that some of these diagnoses are valid, here are some of the orders and some of the recommendations for how we might want to tease at that particular condition. We're bringing that in a responsible way. We we are always ensuring that where appropriate, there's always going to be a human in the loop. But where there are tasks that we are asking people to do that is way below their level of license, if you will, that we can help automate that. I tell our teams that we're trying to create as many semi-autonomous tasks that can be triggered by different protocols, but that there's a human in the loop. That as a clinician, whether you're a nurse or a doctor, that we want you to operate at the top of your license. So one example is that provider co-pilot that we spoke about earlier, where we are able to, and Amy kind of alluded to this, we can start to review the chart through an agent and bring forward a summary of what I need to know before I walk in the room to see that patient. We call that our pre-visit summary. Oftentimes, if you look at the data, clinicians are spending a large amount of time hunting and pecking in the electronic health record, looking for, why am I seeing this patient? What's been going on with them? Especially patients that they don't know. And as more and more fragmentation happens, there are more and more situations where doctors are being asked to see patients maybe for the first time or covering their colleagues, etc. So pre-visit summarization, and then helping them understand during the visit, how can I help? What are the care gaps? What are the different pieces of information I can surface up? If I'm a kidney specialist, can I surface up the most appropriate testing so that I can make the most appropriate decisions while I'm with a patient? After the visit, can I ensure that all the appropriate documentation has happened, not just so that I can submit the bill, but so that presenting the best care possible for that patient? And can we do so in a bit of English and not gobbledygook, so the patient walks away with a better understanding of what we're asking them to do? And then can we trigger off those agents that Amy spoke about? So if we need a follow-up visit with the patient, can we have a scheduling agent automatically with the appropriate permissions call the patient up and go through that process in a much more efficient way? So really, to answer your question, Abdul, we're bringing this to almost everything we do. Things that we have traditionally done through Scotch tape and baling wire, we're asking ourselves, can we use a co-pilot? Can we use an agentic uh, uh, agent to do this, or an agentic workflow to do this? But more importantly, everything we do to help our customers prepare for the solutions on the back end, in the middle, and in the front end, we're asking ourselves, can we re-engineer our own processes with support from our partners like you all? Can we start to really reimagine what the solutions might look like, not only for the users, but for us as developers of those solutions? So the answer, it's pretty much ubiquitous within the company now.
Right. I love that. And I want to underscore something you said as well, because we know the National Academy of Medicine, others, they're really looking at the use of fairness and equity in AI.
Absolutely.
And what you're saying is, and we want to underscore this, that there's an appreciation we need to have and bring to the table, which you do, that acknowledges the roles of developers, right? And the technology side with the adopters, right? Which are the clinicians and the administrators. And that's really essential. Having a human in the loop, the other things you mentioned. And I think that is so key.
Yeah, we actually have an internal AI steering committee to ensure that we're doing this not only internally, but with our partners and with our customers and our community in general. We're members of the Coalition for Health AI, for example, that we're doing so in a responsible manner. And I think it's going to be incredibly important. All of us are going to need to see a physician, and we need to know, are we seeing a physician with AI, or are we just seeing AI? And most of us are going to want to see a physician who's using AI.
That's right. That's right. Well, Amy, you're right in the weeds here, in the thick of it, with your customers and the developers. Where do you see the biggest opportunities for AI-driven healthcare in the next 3 or so years?
Yeah, so I probably have a practical answer to that and then a little bit of an overview answer. I think at the highest level, what we see is something we've always wanted, and it's actually in your title, Abdul, and that is true population health at scale, right? In many ways, we've ended up thinking of population health as just this tiny thing called value-based contracting. But all of us have actually wanted, and I know as physicians yourselves, to be able to provide consistent care that gives you the type of insights you want at the point of care and prepping for care, follow up for care. So that it isn't dependent on things like, well, this is the payer contract. This is a Medicaid patient, so I can only do this. Or I don't have those tools because we didn't buy them to use them for our uninsured patients. How do we use these advancements to make it really possible to do things like have InNote available for every patient? Every time a provider or member of the care team opens up that chart and has the patient 360 and has those enhanced insights and can use things like agents to do the contacts post-discharge for any patient. Because we are able to bend the cost curve with technology to now bring that sort of white glove service, if you will, and those extra investments we currently make only on certain patient populations where there's the business model to go with it. So the promise here is being able to achieve true population health at scale by being able to provide consistent care to all populations: uninsured, underinsured, Medicaid, Medicare, commercial, fee-for-service, prison populations, public health, being able to do that in various environments as well, whether it's acute, post-acute, the home, virtual, and to all those different care teams that right now just cannot manage it. There is no amount of humans that could let us fulfill that promise right now. But with AI, with technology advancements, with the things that we're now able to do with cloud technologies that we just couldn't do before, we really, truly do see a rapidly accelerating future that makes this look not like a pipe dream, but something that is real.
Thank you. It is an exciting time. I think we all agree. So we're going to go to our last question, which really brings it together, right? I want to really understand more, and I think our audience would appreciate learning what's next in Innovaccer's journey to transform healthcare. Anil?
Yeah, I think it's something that Amy spoke about around population health. In my career, and I've been doing this for 25, 30 years, we've been thinking about what does personalized health look like? And it's been elusive. The data's been elusive. The patterns have of what we need to do for individuals has been elusive. And so we have had no choice but to operate healthcare at a population level. What's good for Mr. Smith, who may or may not be representative of the studies that show lowering cholesterol might be beneficial to that degree, we really just don't know. So I think one of the biggest things that we're focused on is how do you now make that transition with the advanced tooling, more data, more specific data? How do you now start to make that transition from just population health to a population health centric approach to personalized medicine, whether it's digital health, whether it's traditional therapeutics, or some of the advances that are being made on asynchronous health. Not everyone needs to see a brick and mortar physician every single time something comes up. There's changes happening in terms of venues of care, and Innovaccer wants to be in the middle of that transition, where we are really trying to drive value, meeting the patients where they're at, thinking about how it is that we go from what is the absolute right thing to do for an individual patient, respecting the needs for population health and respecting the fact that someone has to pay for all this care, but what is the right appropriate thing to do? So that's one. The second is we now have for the first time, have the ability to start creating a single source of truth between all the members or all the partners of an ecosystem, whether it's the health plan, the provider, the patient, the innovators like pharma and device manufacturers, who all need to be part of the same ecosystem, because the cost of healthcare and the way we're spending money on healthcare is not sustainable. As Amy kind of alluded to, we need to start thinking about what does a patient 360 look like when it's really a member 360, and what does a member 360 and a patient 360 look like when we're trying to collect data to see what therapeutics work and what therapeutics don't work or don't work on every patient. So for us, it's making sure we're collecting all the data that's needed, and then trying to connect all the different players within the ecosystem, going beyond the patient, provider, and the plan, and really thinking about the rest of the industry and thinking about folks who are really trying to innovate in this space.
Mhm.
Let me pause there and give Amy a chance as well.
Thank you, Anil. Amy.
Yeah, just expanding it on that is thinking about the business model that underlies all of this. For better or worse, healthcare does have a business model associated with it. And so how can our platform, a health intelligence platform, really change how money flows, how information flows, how patients flow, how the providers are engaged between them, as Anil said, to take down that friction. And I think the other thing you'll really see is this sense of moving from where do we stand now to predictive and prescriptive ability to support our caregivers, the patients, and the care team, so that we move from what does my business look like right now to what could it look like, and therefore how can I bring these tools into caring the care environment, and even better, to a wellness mindset, not just a care environment. And along with that comes things like we have an ability to do proclivity models. It's not just is there a care map or a care gap, and we were predicting that there could be a care gap, but is there a proclivity for this patient to even respond if I reach out? And what could change their willingness to respond? So I think you'll see a depth going into our tools as well that brings the breadth of the ecosystem that Dr. Jain talked about, but then also goes to capabilities that really change that ability to provide hyper-personalized care and productivity.
Excellent. Well, this has been really, really helpful and informative. I think if I could just boil it down to the three takeaways. Number one, you've really captured our understanding of how healthcare is data rich but insight poor. And Innovaccer, your platform, your offerings, helps customers bridge those gaps with interoperability and analytics to drive engagement. I think the second point is that to really achieve this vision of harnessing data, AI, and so on, it starts with your data strategy, right? And that includes an understanding of the governance around data that your customers have, the analytics that can be brought to bear. But then it's really looking and working backwards to understand what their needs are for patients, for providers, for administrators to drive that ROI. And then the third, which is really exciting, is that we know that AI and automation, there really are enablers and accelerators for these improved outcomes when they're used thoughtfully, right? With guardrails that you've described to enable that broader vision that we share for population health. So I want to thank you both, Anil and Amy, for your time today and for sharing with us this information about Innovaccer's compelling opportunities to help their customers. Thank you.
Well, thank you.
Thank you.